All right, moving forward, as we now stepping forward into a segment that truly brings together the diverse expertise and real-world perspective. Because when it comes to precision medicine, it is about convergence of ideas that drives the real progress, which is about shaping the future of precision medicine through comprehensive multi-omic molecular profiling. So as precision medicine continues to evolve, multi-omic molecular profiling is becoming central to how we understand disease, enabling more personalized, predictive, and precise approaches to patient care. And to lead this discussion, it is my honor to invite Dr. Neeti Raizada, Principal Director, Medical Oncology and Hemato-Oncology at Fortis Group of Hospitals, Bangalore. Please join me in welcoming her on stage. And joining them, we have an esteemed panel of experts, Dr. Rajat Chanana, Director, Medical Oncology at Dharamshila Narayana Hospital, Delhi. Dr. Aditya Sareen, Consultant Medical Oncologist at Sir Gangaram Hospital, Delhi. Dr. Jehan Dhabar, Consultant Medical Oncologist and Hemato-Oncologist at Jaslok Hospitals, Mumbai. Dr. Vaibhav Chaudhary, Director Medical and Precision Oncology at Nanavati Max Super Speciality Hospital, Mumbai. Sir is on way, he'll be joining us midway the discussion. And Dr. B.K. Smruti, President of Indian Society of Medical and Paediatric Oncology and Medical Oncologist at Leelavati Hospital and Research Center, Mumbai. Ma'am was about to join, but we just got an update that she has stuck somewhere and she will join us later in the day. Over to you, ma'am. Slides.
So a very good morning yet again. I'll actually try to do a more clinical presentation, and I'll request anybody who has questions in between also can pitch in. And of course, the medical oncologist sitting here also can probably just pitch in and tell what they think. So we'll be talking about the future of precision oncology through multi-omics as the target. And here we know that cancer is a disease of the genome. And genome refers to, of course, DNA, RNA, and not just the tumor, but the tumor microenvironment as well, and then how environment interplays with causing cancer. And when we are treating, we have to keep all these things in mind. Well, yes, as everybody mentioned, probably a couple of decades back, we would only think about non-specific tumor growth, non-specific mutations getting accumulated, and that's what we were treating. But a lot has changed after 1998, and especially after 2016, which was called as the war against cancer, which was launched by a US president. But the way we think of things now is entirely different, and we have our esteemed panelists who have been practicing in and day out. And not just that, our training has changed. The way we train our first years have changed. So the entire way we think of oncology is based on this. And of course, this is what is a multi-omic approach. When we target only the genome, it is genomics. When we go at the translational level, when we go at the RNA level, it becomes transcriptomics, epigenomics, which is the environment play. Now we talk about single gene omics. A lot of it is spoken about in cancers like small cell lung cancer. Proteomics, well, it is still not implemented in practice, but a lot of research around it and integrating it with genomics. Not just that, now metabolomics, how the enzyme interplay, how the lipids interplay happens, which is lipidomics. And then, of course, integrating it, all the data which is available by machine learning and AI, that is known as AI-omics. And that, again, that is what we all have been talking about. A lot of landmark papers, a lot of clinical work, but has it reached bedside is what we'll be discussing today. So this is what it is. When we talk about the genomics, we talk about single nucleotide variants. We talk about whole exome sequencing, whole genome sequencing. And yes, genome sequencing brings a lot of data, but does it bring actionable data? So we move down to whole exome sequencing, and then of course to structural variants, the individual factors which work on. When we talk about transcriptomics, it's basically RNA sequencing, and that is known as circulating tumor RNA, whereas genomics is circulating tumor DNA. Epigenomics, which deals with methylation and ATAC sequencing, and then chip sequencing as well. Proteomics, in which mass spectroscopy is done. Mutation, when we talk about the metabolomics, it is again NMR sequencing. And again, this is at a research level, even in Mumbai, as at this point in time. Microbiomics, which all we know about gut health, we know about how it plays not just in GI cancers, but in normal lifestyle diseases as well. Spatial genomics and chromatin reorganization. Well, this is investigational, but again, spatial transcriptomics and spatial proteomics, how the entire structure in 3-dimension or even a quaternary dimension it's spoken about. Liquid biopsy is known as dynamic monitoring, which is what we do at a routine level. And then when we integrate it with tissue biopsies and liquid biopsies together have a higher value, as we'll discuss subsequently. We often do MRD monitoring, which is known as minimal residual monitoring, in solid tumors and liquid tumors. So there has been a lot of work in cancers like lung cancer and of course colon cancer, even breast cancer now, and in liquid tumors like of course leukemias and myelomas. Ex vivo and silicon modeling, and of course digital pathology and AI pathomics, which again we practice on a routine basis. The clinical challenges remain standardization and validation of these platforms, and what exactly are the platforms we are using, and is it based on good data? So these are the subtypes of DNA sequencing, and what do we do in that? We look for SNVs, CNVs, we look for tumor mutation burden, and then of course we look for structural variants and gene fusions. We look for homologous recombinant deficiency, known as HRD. And then, of course, MSI or MMR deficiency, which decides whether immunotherapy will work or not, other than TMBs and certain other markers. Some of them are not so perfect, like PDL1, but yes, these are some of the ways we decide immunotherapy will work or not. And a lot was spoken before this about individualized vaccines. So all these data is also need to find out whether we can individualize a tumor vaccine for a patient. So integrating genomics. Now this is the data which we have, and this is one very large data on lung cancer. Lung cancer genomics have been in practice for almost 20 years now. And what we saw as a disease which with chemotherapy patient may just do well for 9 to 12 months, maximum of 13 months. Now it's years together. Dr. Kumar Prabhas also mentioned ALK positive lung cancer. We have data in which overall survival is not reached. So when the patient started a particular drug, they have not even reached an endpoint. Most of the patients are still alive at the point of, there have been subsequent analysis at 3 years, 5 years, and they have done extremely well. EGFR positive stage 4 lung cancer have a median survival of 5 years. And if you look at an individual, they could survive for decades. So that's what we are talking about in advanced cancers as well. A ROS positive lung cancer or an enteric positive, any tumor, would have an extremely good survival. Deficient MMR positive, any cancer, whether it's colon cancer, GI cancer, even endometrial cancer, will probably have a survival as good as a healthy person. So what has changed? When we do a deep sequencing, we may find that almost 17% addition of EGFR mutations, the exon 19, which is the most common one. When we look at point mutations, 22% addition have happened based on the CGP platform we are using. 15% additional HER2 mutations in lung cancer, which is a bad subset. So not just a good subset, we can identify subsets with poor prognosis or those who don't do as well. ALK fusions are another very unique subsets which we need to identify, and that's why the importance of RNA sequencing. And this 25 to 35% new additional ALK positive fusions are detected if you do a good sequencing. So I'll start with all my panelists. With Rajit, what are your experience when you talk about comprehensive coverage in lung cancer?
So definitely CGP should be done whenever possible, but it may not be practical for for most of our patients. So if we do end up doing CGP, we may be able to find some more mutations which are generally missed by a lung-specific panel. So whenever possible, CGP gives us an idea regarding what actionable mutation can be there and what we can explain the prognosis also, and it also gives us some of the resistance marker which can which can help us make the treatment better.
Very rightly said that not just the mutation, but what causes resistance parallelly as well. Dr. Aditya, what are your thoughts?
So, India is a very diverse country, and the geographic location where a consultant is practicing, that carries a huge impact on this particular decision making. And I was hearing Dr. Sevanti where, it's like precision all the way, and absolutely, I mean, there is no question about it. And given that all the green signals are there, obviously any oncologist sitting anywhere in the whole world is going to do an NGS CGP. There is no question about it. Currently, what is happening now is that because of the availability of, hotspot NGS, and that too, technically free. So most of our patients, like you just heard in the previous talk, that 5,000 patients have been screened via the Lung Alliance group. Right. And I think out of 5,000, maybe 200 we would have, contributed. And if you see the hotspot, the problem with the hotspot is these problems that you have, rightly pointed out, that it misses mutation. And if you miss a mutation, you change the trajectory of that particular case, and there is no coming back from that. And once we have those kind of free hotspots, and then you do, deeper sequencing, the process changes altogether. And we have been able to pick up, 10 or 20, new mutations out of 200. So I think the data is there to do CGP. You have to know if a patient is affording, if your experience with CGP and interpretation is good enough. I think there is no question in anybody's mind that CGP is the way. On top of that, now we are doing liquid and solid both. Right. So the concept is changing. When I was getting trained, it was purely, somatic, worry about somatic. And now look where we are. Within 3 years, we are doing combo panels of NGS, CGP, both solid and, germline. So for me, it is the way forward.
So how many percentage of your patients actually agree to do this test in Sri Gangaram?
So yeah, at Gangaram Hospital, we have a very diverse practice. I see patients who are, below poverty line, and I see patients who are, maybe running a huge global MNCs. So for me, it has to be in sync with that patient's profile. I can't just ask a patient's family who is earning, maybe a 5,000 rupees per month or 10,000 rupees per month to go and do an NGS CGP. And on a vis-a-vis, on the completely contrasting side, I have a patient, who are, business owners, running industries. For them, it's like the discussion is, yeah, doc, do whatever you want. Just make sure my patient get best of the best treatment. So the answer is never going to be the same. It changes as per the patient's resources and constraint. I don't like to push my patients to do something which they are not comfortable with.
Dr. Jihan, what do you see in normal practice, and what do you do? How do you counsel your patients?
So, absolutely. So I think there are two different things that we do. One is, of course, the ideal scenario where I would like to do a complete CGP, liquid plus solid for all my patients, get the maximum output. But it's not really practical in the real world to send both. Some patients can afford it, some cannot. And just to tell you, I would prefer sending a liquid biopsy for all lung cancer patients, especially it covers the DNA and RNA, because many fusions can be missed out, especially the targetable ones, the good ones, ALK, RET maybe. I have a patient, today morning I took rounds in Jaslok and came straight here. So I have a patient who's intubated on a ventilator right now, came with gross effusion and a brain met. A biopsy was just done. In the meanwhile, I sent a liquid biopsy because my pathologist told me on the phone it's query adenocarcinoma. So I'm hopeful that we'll get some mutation in her liquid biopsy. So, and it's a potentially life-saving for her. So I think such scenarios sometimes for lung cancer can be absolutely game-changing. She's a 38-year-old lady, of course non-smoker and Indian. So I'm quite hopeful. Looks like a driver mutation positive lady. So hopefully, so these kind of scenarios I think are where we have to send a liquid and solid, because and where sometimes cost takes a secondary seat. But yes, I think the
So
game
do you
is
do
changing.
limited panels sometimes? Like in this, you would possibly be thinking of some important, more common.
Because I want a quicker report also, because the solid will take around 20 days, liquid will come in probably 10, 11 days. So I think in this scenario is really.
So Dr. Vaibhav, how often do you send both tissue and liquid? How often and which do you prefer if you're sending one?
Usually prefer solid. If sufficient tissue is there, I stick to it. If there is an urgency, there is some doubtful thing, because lung, always tissue is the issue, and my pathologist actually tells me that scanty tissue is there, then I would actually do liquid, and whenever that specimen is available, do a combination test as well. Depends on scenario. The thing is here, I have been hearing too the comments that not everyone in our country, we are a diverse country, yes, not everyone can afford a CGP, right? And as you showed in that graph, that a lot of things are missed on routine. That has been my experience. I have been practicing, I'm trained in Tata, I've been practicing in private, various setups for 10 years. So the thing is, ma'am, one thing is, if you want to do precision oncology, you cannot do it without personalizing. And when you personalize, you not only see the patient, the financial status, the comorbidities, and the urgency of treatment. So all these things are taken into account. If I have to find out EGFR mutation, the best drug is Tagrisso. It will cost 1 lakh rupees for a month. If I have to find ALK, the best drug is lorlatinib. It will cost 1 lakh a month, right? So when I see that, that is what is at stake. And my patient who is a non-smoker, middle-aged female, I will actually push for a CGP, because I don't want to miss out on such mutations when the treatment cost is exceeding than the one-time CGP cost. So I will definitely counsel them. But on the contrary, if someone is having like a BPL patients are there, we do see them, charity patients and a lot in our Nanavati Max hospital. So there we routinely stick to small panels, because I am not going to offer them Tagrisso, I am not going to offer them lorlatinib. So there, if something misses and they come second time around, we try to still do an NGS, because we do try to enroll such patients in clinical trials also. That opens a big window. If you have this mutation testing, that is another big plus of CGP. Something is there where some mutation and already approved therapies are available in the market, FDA approved thing. Some things are there which are in the pipeline. We are aware of lot of, across tumors I am talking, lot of promising molecules are in the pipeline. The basic thing which is required for recruitment in active recruiting clinical trial worldwide is a CGP. Based on those mutations only, we can actually guide, or in US actually they guide if they have something in their center. So it is something which is become essential. If you do a small panel, then obviously you miss out on that also. So I am a pro CGP guy, but combination or liquid I do very selectively.
And then on top of it, you know, even if you're giving osimertinib, whether it will work as good or not,
Yes.
or as the data says.
Yes.
Based
Yes,
on
ma'am.
the
Resistant mutations, and then whether I need to combine osimertinib with chemotherapy, whether I need to be ready, and that actually changes my counseling to the patient.
So these are some of the reasons why we choose liquid versus solid. Liquid is just a blood sample, and tissue is, as everybody said, issue as well, especially in lung cancer. The major issue is logistics when we are sampling both tissue and liquid. Of course, TAT, turnaround time, is also very significant, because tissue sometimes take a longer time, where the liquid can be done on rapid NGS platforms. Actually, now platforms actually give report within 3 to 5 days, which saves a lot of time. If you're located in another country, even for recruitment, sometimes the recruitment period in a clinical trial is 28 days. Whereas in India, we can offer therapy in 3 days' time. I mean, look at the exceptionally remarkable difference between West and East. We can have a patient walk in, same day do a biopsy, next day do a scan, a whole body scan, and third day we have a pathology report and a staging scan sitting on our table. And if we have already sent NGS on that day, by 5th day we know patient is ALK positive, EGFR positive with a co-mutation, whether TP53, and they are going to do badly or they will respond very well to a therapy. So this is the power of India. We fail to realize that the cost of treatment in East versus West is a fraction of what we can think. And yes, even the less affording segment can pay. And there are a lot of platforms which help, even in testing. There are free samples, free coupons we use from time to time. for all our patients, because we know the value of getting certain results. And we, of course, there are treatment which is offered, patient assistance program which is offered in India, which is not offered anywhere. And of course, the value of generics. We have generics in the entire segment, and now we have Indian generics of immunotherapy as well. So concurrent testing, there have been landmark studies, Nile study, which made a reference of doing tissue alone, doing liquid alone, and the spectrum of overlap. And everything has a value. Doing both together definitely is much more valuable, and whenever possible, both are required. And sometimes get a biopsy, you have a strong suspicion, like everybody mentioned, a patient with brain mets. On that day, we can send a liquid sample, do a biopsy, and by the time we have a tissue biopsy report with an IHC, we also have a liquid report with mutation. So in the next 5 days, we have both at the same time, and we know what to start, chemotherapy versus a directed targeted therapy. Nile study and then PEN2 study, which highlighted the importance of doing both. And you can see the remarkable difference in the bar chart. So I start with questions based on cases. Now this is a metastatic colorectal cancer. Interestingly, this is a patient with dual colorectal cancers. So she's a 61-year-old lady, and she had no family history of colon cancer. And initial presentation was just abdominal pain and diarrhea. An ultrasound was done initially, subsequently a CT scan was done, and there was an ascending colon mass, that is the right colon mass, and then there was also a mass in the distal colon. She had small adjacent mesenteric lymph node. When a colonoscopy was done, there was a large obstructing mass in the ascending colon, and also a non-obstructing mass in the sigmoid colon. Normally, a gastroenterologist will biopsy both the lesions because they are at a distance, they are not located around the same area. So both biopsies were done. And these both biopsies were moderately differentiated adenocarcinoma, both the ascending colon and sigmoid colon. So there were actually 2 malignancies, both being positive. Molecular testing was done because dual malignancies are not as common at presentation. So MSI was tested by IHC, and there was a strong suspicion, so PCR was also done. And both methods showed that it is negative. Surgical patient was subjected to surgery because there was no metastatic disease. So surgery was done, but during a diag lab, there was peritoneal carcinomatosis. So it was actually a stage 4 disease, which was not seen in a scan, but on a diag lab, we found that there are peritoneal carcinomatosis and bulky nodal disease. So tumor was deemed unresectable, and only a palliative ileostomy was done because there was an obstructive lesion and needed an ileostomy. Subsequently, biopsy was done of the peritoneal carcinomatosis as well. So patient was sent, we normally for a metastatic disease will do a smaller panel, but in this a larger panel was used. So I'll start with Vaibhav. How often do you do limited panel in colon versus larger panel?
Colon, actually, we stick to most of the time limited panel because there are not many, it's not like lung. There are not many things which we can work around. But again, the picture is changing there. Again, we are now getting more and more target therapies. So we do stick to limited panels for now. But certain places where we, like this patient, different presentation and all, we would like to have more information on the tumor, and if patient is affordable, we can actually do it. So that right now it won't change my line of management, but later on there might be more options if I have a baseline report.
Right. Dr. Jihan, you would have done what panel? And in this, I mean, would you have thought of liquid biopsy at all?
No, in a colon, I usually start with a limited panel only, and I would not have done a liquid
limited
biopsy.
panel means you would want to do HER2 testing and all extended biomarkers as well?
So just what I require is I would not even do a PIK3 to start with, but an all-RAS, an MSI, HER2, and maybe a BRAF also, but we don't have access to.
Dr. Aditya, what would you do? And in this case, would you have sent both the samples for colon panel, or you would have sent only sigmoid or only the ascending colon? Both samples.
I think there are 2-3 questions here, so I have to take it sequentially. There is no one answer. So obviously, so the first tick mark has to be that the finances, if not a constraint, then obviously we all know the one histology is of ascending colon, the another is of sigmoid. We all know that right and left they behave very differently, and our targeted drug selection is going to impact hugely if we just send only one NGS. So for me, in an idealistic situation, I think both the samples should be sent simultaneously to run it one for the left side and one for the right side, and you can have a varied interpretation of those results. And on top of that, again, if you don't have financial issue, I would go for the liquid biopsy upfront as well. And why I am saying this, you can counter question me, doctor saying that this is not the standard of care guidelines, even the NCCN states that. But I think guidelines are there to support us. It's the practice and the expertise that we have gained over the years that is dictating my answer in this. If I would have been a student and I have to pass my examination, I would have just said, just send the NGS on the solid. You did not need to send the liquid, but I think another 3 years, this answer will change and the guidelines will change.
Right.
So for me, either, we adapt right now or
So
adapt later.
would you want to do liquid and then do a monitoring subsequently?
Absolutely. I mean, we have just seen the data from Tai et al. For stage 2 and stage 3 patients who are, ctDNA positive and who are ctDNA negative. And there is, the technology is moving. The cost becomes an issue. So let me re-emphasize it again. The message should not be, every patient is getting NGS, CGP, every patient is going for the liquid biopsy. No. Like we all have, our own unique identification numbers. We have our own unique Aadhaar cards. So there is an absolutely new way to handle each and every case. You can't just blanketly or put an umbrella to this case, or we are not treating cohorts, we are treating individuals. So you have to individualize, and this is what is all precision medicine about. For me, I would have sent both-sided samples for NGS along with the liquid upfront.
So Dr. Rajat, this is the sigmoid biopsy report, molecular profiling, and very similar for cecal biopsy as well. What would we start in terms of treatment? There's a right-sided and a left-sided malignancy.
I think first to answer the previous question, since this is a unique presentation and left and right we know are different diseases, so this patient should have been sent for both solid and liquid. And based on this profile and presuming that this was done from Guardant because it's written Guardant, so MAP2K mutation means that probably would not respond to cetuximab or panitumumab. And the markers of immunotherapy are also not good. So I would start with FOLFOX, would not add BEV because patient is in impending obstruction, surgery not possible. So would start with this patient with FOLFOX.
Right. So as you rightly said, FOLFOX was started and none of the targeted drugs was used, not EGFR target, not VEGFR target, because we couldn't have used EGFR, and BEV couldn't be used because of obstruction. So subsequently, as Dr. Aditya said, molecular profiling was done because the patient did not do well and there was progression. So at that point in time, a liquid biopsy was offered, and this is the liquid biopsy report. So what would you do, Dr. Aditya? And what would you think when you see this?
Yeah, so I think there you can see the BRAF, which is classical, V600E, and you have these MHC clone along with the BRCA. I think it must be a duplication. ARID, I think BRCA, ARID, these are components of the HRD. Along with that, the most notorious mutations, TP53. I have still not been able to
And look at the blood
this.
TMBs.
Yeah, I was just coming to that. And a tumor mutation burden of 141. Obviously, your sensors are up now. Your sensors are hugely up because you have two confounding things in this patient. One is you have BRAF V600E. We all know you have the tumor agnostic approval for these agents. And side by side, simultaneously, you have a TMB of 141. Okay, so a very difficult question. But then again, there can be two scenarios here. If patient is progressing beyond FOLFOX, and I have this report, I would like to go for a combination, if feasible. Then again, minded, if feasible and patient agrees to go for both BRA V600E and IO. In idealistic world, let's say if I have to practice tomorrow, I'm not saying now hypothetically, I will straight away start him on IO with at least some chemo backbone.
So Dr. Jihan, what would you do?
So I think we're treating two clones out here. One is the MSS clone maybe, and one is the MSI high, molecularly hot, immune-sensitive tumor clone. So, and his patient has progressed on FOLFOX. So I would change my chemo backbone and of course, add immuno. Can we treat him with only immuno, like a Nivo-EP combination? I don't know. I would still add FOLFIRI with chemotherapy. with immunotherapy.
And you're saying any IO works. In colon, we have data for all the immunotherapy agents.
Exactly, yes. So I'm more comfortable if I'm using a single agent, I would think of pembrolizumab or Nivo-EP in a combination, which is
Weber,
considered
would
magic
you have
bullet.
an indication of whether it is sporadic or heritable or something when you see this report? There was no family history.
Yeah, yeah. There was no family history. That is one thing which goes against it. But with BRAF, actually, typically we don't look at the lynch if BRAF is visible
Right.
there. So I would, but still, that doesn't change my treatment choice. I will still
Right.
go for immunotherapy. And BRAF, yes, I will keep in mind. I can add on later on.
Yes.
So that is what.
So
I will do.
basically an MH6 only positive with a BRAF positive. We would think of sporadic, not, not Lynch. And of course, with such high blood TMBs and MSI high, we would definitely want to add one of the IOs. And now we have evidence of Chinese IOs as well in colon. So that's where we are. So this was a very unique case. This is definitely not a standard case in which actually peritoneal biopsies were done and that showed MSI high. So very, very weird, but then that's the importance of liquid versus solid. I'll go quickly to the next case. Well, talking about RNA profiling. And what do we find in RNA profiling? Well, we look for gene fusions, and everybody mentioned the importance of gene fusions. Finding gene fusions in certain diseases, again, could be, have a huge value addition in terms of patients living for an extended period of time. We often do gene fusions in blood cancers as well. So we do in chronic myeloid leukemia, acute promyelocytic leukemia, which actually just finding out whether there's a PML-RA can have 98% survival. So you see the importance of finding these fusions in any settings. You find molecular subtyping. So that's the difference of diagnosing an early breast cancer and treating them with chemo or treating them with hormones alone. And doing tests like PAM50, a MAMA print or Oncotype DX is based on RNA profiling. And that again decides whether a young patient will require chemotherapy with hormone therapy or only hormonal therapy, and elderly will require what? Based on good genes and bad genes. Immune cell deconvolution is another technique, splice variants and expression, and of course we are moving to single cell RNA sequencing. And can't forget the value of NTRK. We all know that any rare cancer very likely to have an NTRK mutation. Common cancers may have unlikely NTRK, but a rare cancer often will have NTRK. So this is integrating transcriptomics, where DNA actually transcribes as messenger RNA, and that's what we are checking. And this is what DNA fails to recognize: certain type of intron regions, repetitive introns, low tumor contents, and of course complex rearrangements. So moving on to the next case. Now this patient was diagnosed in January 2022, where the patient had new onset seizures, and which was involving the focal seizures, involving the upper limb, left upper limb, with headaches and intermittent confusion. MRI brain showed a 4.5 centimeter lesion on the right frontal lobe, and therefore a surgical intervention was done. It was a subtotal tumor excision because it was in the critical area of the brain, and the histopathology showed it's a diffuse astrocytoma. The diffuse astrocytoma typically requires an IDH1 subtyping. So this was an IDH1 positive astrocytoma, which was had Atrax loss. There was P53 overexpression, which is unusual, but then this patient had. And of course, Ki67 was 8 to 10%. So it was classified as WHO grade 2 IDH mutant astrocytoma. So anyone, maybe Vaibhav can tell us what we would normally do after excision?
Yeah, normally we actually routinely used to send this patient for radiation, and that was the norm. But with this kind of a scenario, some people actually might offer vorazidenib also in this kind of scenario. The positive study is there. But still, currently we have not adopted that. Drug is now becoming available in our country, yes. And we might be able to give that choice to the patient if they want to avoid radiation. So there is some evidence there. Right. But right now, radiation.
Dr. Jihan, what would you do?
I agree. So I've had, for the young patient, I don't know, how old is this patient?
62.
62. So then I would probably think about radiation and temozolomide only. I have a 30-year-old patient who I've offered vorasidenib in an IDH mutant. I wanted to spare him from radiation. But in this case, yes, temozolomide and radiation. I will get an MGMT methylation done also.
Right. So subsequently, 2 years later, patient had, again, clinical progression. And that time, patient was already on MRI follow-up, and the MRI showed there's a recurrence in the same site, and therefore a resurgery was offered. And this time, it was upgraded as a grade 3 astrocytoma. And again, a temozolomide re-challenge was done with limited benefit. So, Dr. Aditya, would you think of profiling here?
So obviously, now at any point you feel, you have a window, you go for profiling. You do it, and you do it. Even if it is in the first of the presentation, I would have, loved to do it, but then again, it's not. Sometimes, these patients are never even referred to us. They are only being treated by the radiation oncologist, and they land to our OPD once, they have exhausted those kind of scenarios. But doing an NGS, obviously, we have to do, and we are desperate to find mutations in order to save the patient's life, and
So
going ahead with solid and the liquid.
You'll go with solid and liquid in this case?
Yeah, absolutely. If the solid was not done, and let's say if the recurrence is there and I have to prove it, might as well just prove that recurrence and send the solid simultaneously.
But in CNS tumors, the data on liquid is quite limited at this point in time, especially in grade 3 and grade 2. So
I am more interested in the tumor agnostic mutations all the time. So that is the intent. Whether I find that in the somatic or whether I find that in the liquid, right. It's like we all know that, finding tumor agnostic mutation is finding a needle in an ocean. If you find that needle, the whole journey changes. And I'm sure that you will showcase how his journey changed.
Dr. Rajat, what panel will you choose in this patient? Would you look for any particular sequencing, any particular lab where you would recommend?
This is probably a low-grade glioma which has been transformed to a high-grade glioma. So I would want to prove that and would like to do a CGP, mostly solid, I think. Liquid, I'm not sure. So lab, I think Guardant 360, since this is provided by Guardant, so I'll choose Guardant as the.
But you will make sure that RNA sequencing is a part of that, and not just hotspot DNA sequencing.
Yeah, definitely a panel which has both the DNA along with RNA.
So, sir, this is the report. As you can see, this is a GCAP1 NTREC2 fusion noted. The IDH1 was, of course, positive, and then there was an NF1 positive, and then TP53 and ATRAX. Now, which we had seen in IHC as well. IDH1, ATRAX, and TP53. So there's an NF1, and then there's an NTREC fusion as well. Dr. Rajat, what would you think, and how would you change your line of management?
So I think the purpose of doing the NGS has been solved. So we have found one mutation, that is the NTRK. So we'll target that with the available drug that we have, that is entrectinib. So I'll start this patient on entrectinib.
Any of the NTREC, because most of them will have CNS.
Because we have only entrectinib available, so
correct.
That's why.
So, entrectinib, larotrectinib, or even any new one we can use. So patient actually had a remarkable response with NTREC targeted drug. All of them have good CNS penetration. So even with the primary CNS tumor, patient had near complete response. Integrating epigenomics, which would be the third part, and this is the only 3 parts which we have clinical implications at this point in time. And what do we do in epigenomics? Well, we do methylation, histone acetylation, and BETs. These are the 3 technologies that are used to look for coding RNAs and, of course, non-coding RNAs as well. Now, when we look at DNA methylation, they are like fingerprints. Every tumor has individualized fingerprints, and this is what we are trying to see. So when we have a tobacco-associated cancer, we call it tobacco-related signatures. In a melanoma, we call it a UV-related signatures. So we try to find out the DNA signatures which can actually have therapeutic implication. An HPV signature could actually treat oropharyngeal cancer in a very different way. So these again have very defined therapeutic signals. Now, what do we do? First important thing is cell of origin. Sometimes a patient will come with very advanced disease, and there'll be disease all over the place, lung, liver, bone, brain, and we don't know whether disease is arising from. So there the importance of finding out the cell of origin, which actually tells us by cell signatures or molecular signatures. And then, of course, there are other implications which include microRNA testing, which includes ink RNA testing, which are long non-coding regions of RNA, and of course mRNA profiling. And this is what has changed when we do liquid biopsies. So this is focused on doing liquid biopsies alone. And these are the tumor types in which it has done remarkable difference, including breast cancer, which is globally the most common cancer, lung cancer, gallbladder and cholangiocarcinoma, which is a very important cancer in India, head and neck cancer, and of course colon cancer and gastric cancers as well. So I will go to a question quickly. And where do we do in lung cancer? Well, lung cancer is, everybody said, it's a heterogeneous disease. Most common subtype is adenocarcinoma. The next common subtype is squamous cell carcinoma. But a rare, very aggressive subtype is small cell lung cancer, where we don't have defined therapies. And we use commonly chemotherapies and often immunotherapies. But there has been single cell omics which have been tried and tested, not in clinical use, but then molecular signatures can sometimes define how we do. So I will just go to the question. This is a 62-year-old never smoker woman who was diagnosed 22 months back with metastatic lung cancer. This was an adenocarcinoma on pathology and had EGFR exon 19 deletion upfront. Non-smoker woman of Indian ethnicity and was started on osimertinib. At 20 months, she had a near complete response. And recently, she came to the clinic with progressive cough. There was bone pains as well. And a scan was offered, which showed that she had bilateral increasing pulmonary nodules, and there was bony metastasis as well. So, Dr. Dabar, how will you proceed? What will you talk to the patient and do?
So I would definitely think of sending a liquid biopsy here, and also probably do a repeat solid biopsy as well, a proper CT guide biopsy as well, because there are various mechanisms to the osimertinib resistance that we see. Of course, one of them is MET amplification or MET mutations and HER2 amplification, and also rarely a histologic transformation. So I would definitely do a CGP at this point of time, preferably liquid plus solid, or at least a liquid for sure.
Dr. Vaibhav, what?
So this is a typical case where 2 years back, my decision would have been to actually push for and try to convince the patient to take a biopsy so that we rule out transformation. That is very well known that these EGFR positives do transform, and you sometimes miss the plot when you are progressing. So now with this liquid biopsy where epigenetic signatures are there and they are pointing out towards the cell of origin and may give some cues towards transformation as well. If my patient is not convinced at all with a repeat solid biopsy, I will not push for it because it's a multicentric kind of a disease. There is a lot of tumor heterogeneity which actually you can miss by going on just one target. So, and taking a solid biopsy. The ideal test here would be a liquid biopsy, and what more, if we can get some clues towards transformations as well, then that solves the purpose. So this test actually satisfies both the criteria. I will go for a proper liquid.
Very rightly said, but my also question is there are multiple tiny pulmonary lesions and bone-only disease.
You cannot hit it.
We may even not get a very good tissue profiling of this because we only have bone to target. So as all said that, well, we went ahead with liquid biopsy alone, and this came out to be the Gardant report. Dr. Rajat, your comments. So there's an EGFR E746 to A750 deletion positive, which is exon 19. And then there's a MET amplification as well. There's a EGFR amplification as well. And of course, a TP53 mutation, which is 6.2% on, and then an RB1 mutation. You see a spectrum of things. So TMB is 28, MSI is not detected, and tumor fraction is 11.9%. So adequate tumor fraction.
So I think we need to discuss with the molecular oncologists regarding how do we approach, either we follow a Mariposa 2-like approach or we treat the patient as transformed to small cell lung carcinoma, because I'm not sure whether in liquid biopsy can we actually comment the patient has transformed to a small cell variant. So I would be probably more comfortable with treating something like a Mariposa 2 approach and treat with combination.
Yeah, actually rightly said. But then, I mean, that's what we are trying to find out, whether molecular signatures could have importance. And we see TP53 and RB1 both positive. So Dr. Aditya, your comments?
Well, just taking a step back, why are we afraid of getting the bone biopsy done?
No, actually, the process of decalcification sometimes can destroy DNA, and then.
Yeah. So, because then again, it's an anchor patient for me. And so she was again a 62-year-old female having just tibial lytic lesion along with some fibulary lytic lesion and some metatarsal lesion. And that's how that lady presented to me. And this is like 3 years back. And there is absolutely nothing. I have done all the scopies, I have done mammos, and I didn't find anything. So the final, obviously, was to hit that bone and take the biopsy. That showed a GATA3 positive. And it turned out, so I thought,
IHC is very much positive. So.
Fair. And obviously, I was not anticipating and considering, my thought process would be either it can be a bladder, or it can be, breast, or it can be, sometimes in thyroid as well. But then again, I just started her, platinum and taxane. That's our go-to drug protocol. With that single biopsy, I have been able to take that patient on have you ever heard of a platinum or a taxane maintenance? So for the past 3 years, she's on a maintenance.
So she was ERPR negative.
Completely triple negative. And now my contention was again that how can she being tolerant to that kind of paclitaxel in her life? It's like crossed all the limits. Yeah. Whenever I dialed down the dose, used to, fulminate. And at that point, I did NGS and on the liquid. Showed me BRCA, somatic. And in germline, it was negative. Oh. So I think whenever we are interpreting liquid CGP alone, you have to keep all the senses or senses open up. It can never be about lung, or it can never be about thyroid. It can be anything in the whole world that you are treating. And your take on these mutations, I think the driver mutations here being the EGFR, considering the high VAF, I think VAF must be high for it.
35%.
35, and for TP53, I think
6.2%.
So obviously you have the driver here, and you just chase the driver, and you can just ignore the TMB over here.
Right.
Yeah. So
Dr. Dabar, what are your thoughts?
So I'm surprised your patient did have neuropathy with paclitaxel.
3 monthly. I mean, I have NCVs 3 monthly.
So now coming back to this patient, the definite molecular signature is confusing out here, is telling us it's maybe a small cell transformation. But the RB1 is only 0.1%. Right. EGFR is a driver over here. But still, I would not really jump to only amivantamab over here. I would do something that I did pre-amivantamab. I like the ABCP. So atezolizumab paclicarbo or atezolizumab etocarbo maybe for some reason. So it's a desperate protocol, definitely. But a small cell transformation also is a desperate situation. So I would think of combining immunobev with some chemo.
Dr. Vaibhav?
I agree with Rajat's approach that we would first go for Mariposa lichen approach, and then when we
and a bispecific, because both, I mean, we have MET amplification and EGFR,
and
which is
the
about
VAPs
35%.
are higher there, and the small cell, yes, we do consideration. If we are successfully able to treat the upper one, couple of resistance, then the next clone will take over.
You would think of chemo plus amivantamab or amivantamab alone?
No, both. Chemo. I'll give with chemo.
So that can actually, the platinum will anyway target the small cell.
That, yes.
So I think these are the cases we have, and we discuss the management. Thanks so much. Okay.
Thank you, ma'am. Thank you so much. And with this, we have come to end of our discussion. And I would like to thank all our esteemed dignitaries for the incredibly insightful discussion that truly highlighted the multi-omic approaches that are shaping the future of precision medicine. Now, as a token of appreciation and gratitude, I would like to request Dr. Neeti Raizada to please come forward and felicitate the fellow speakers for this amazing conversation. May I have the certificates? Dr. Vaibhav Chaudhary. Dr. Rajat Chanana. Dr. Aditya Sari. Dr. Jehan Dhavar. I would request all the speakers to please come back on a stage for a group picture, and I would like to also invite Dr. Manisha Khurana to please come and felicitate Dr. Neeti Raizada for exceptionally moderating and leading this discussion. Thank you, ma'am, and let's have a group picture here. Thank you. Thank you so much, ma'am.